Welcome to the session of a bifurcation PCI Part 1. My name is Donny Furman. I will be chairing the session with the Professor Nguyen Van Tan. So we have distinguished panelists here, our friends Dinesh Nair, Wang Fuang, Dr. Barak Kailani, Yong Chok Kim, Lennon Lau. And then let's move to our first speaker. May I invite Dr. Frankie Tam. Frankie will talk about all the crush you need to know. Please, Frankie.
Yes, thank you. So it's honored to be here again to see my friends and being invited. So today I would like to deliver the talk about the crush technique, right? So everybody know about the crush, right? So this is a summary of what all the crushes you may know, right? Okay, so we know. Can we have the slides up? Okay, so we know that bifurcation PCI is around 10 to 20%. Bifurcation, we always have the proximal membrane, distal membrane, and the side branch, right? I also want to skip this. All right. So, but nowadays we know that provisional stenting is currently the default strategy. Especially nowadays, we use a lot of DCB, which I would frankly say that it reduces the need of the two-stent strategy. So, especially for the young fellows or trainees, they may have less chances to perform the upfront two-stent strategy. But however, in real life, there are some situations that an upfront two-stent strategy is desirable. For example, if there's significant side branch disease, calcified side branch disease, extensive side branch disease, or challenging side branch access, you may need upfront two-stent. And also, some people may follow the definition 2 criteria, so that these patients, they may need the upfront two-stent strategy. And with the two-stent strategy, there are lots of different terminology and stuff, and there are different techniques, for example, T and protrusion or T-stent or Kudo stent, and of course, one of the favorite methods is about the crush stenting strategy of the bifurcation PCI. And for the crush strategy, there are different iteration, for example, mini crush, nano crush, and decay crush. So today I would like to spend some time to explain to you what are the different types of crush, and also what are the tips and tricks of performing various types of crush stent strategy. Okay, so for the classic crush, it has been described by Colombo many years ago. So 7 French guiding catheter, protrusion of side branch metal stent to the main branch, and then perform the main branch stenting at the same time. But however, the classic crush have a lot of metal, right? And there's a higher rate of failure of side branch device, which causing increasing balloon inflation. So nowadays, not many people perform the classic crush. On the other hand, mini crush, I would say, is one of the very commonly used and we say very versatile approach to perform the upfront two-stent strategy. For example, this is a mini crush, it is 6 French compatible, and we will have both the main branch and side branch access, and it is also good even if the main branch and side branch size discrepancy is big, okay? And I think it is the quickest way to secure both the main branch and side branch if you want to perform a two-stent strategy as quick as possible. All right. So for the mini crush, there are some tips and tricks. So for example, you first want to stent the side branch, but of course, before you want to stent the side deploy the side branch stent, you have to have the main branch crush balloon before you deploy the side branch stenting. All right. And after you deploy the side branch stent, you remove the stent balloon and wire together, and then you crush the side branch stent. The aim of the crush is just to create a passage for the main branch stent. And after that, you insert the main branch stent, and then you deploy the main branch stent, and you do the port before the rewiring. After the port, you do the rewiring, and then you do the kissing balloon inflation. So this is, again, as I've mentioned, the quickest way of performing a two-stent strategy in the bifurcation, and at the same time, you can always have the access to the main branch and the side branch before you do any sort of rewiring. All right, so this is a very quick case illustration. Cystic man, hypertension, diabetes. Can you play the video, please? All the video. So this patient actually have acute STEMI, cardiogenic shock, APO, tachycardia, leading inotropes. Excuse me? Excuse me? Okay, play all the video, please. Free videos, please. Can you have click on the video so that it plays? Okay, thank you very much. Okay, so you can see this is a very extensive disease in the left main, LAD, and circumflex, and this patient is in cardiogenic shock. So we want to do it quick, so we quickly rewire the both flanges. Can you also play the video, free video, please? Yeah, three of them at the same time. Very good. Thank you. All right. So we do some ballooning, and you can see the LAD is undilatable, so we have to do root ablation. Okay, and then afterwards, because as I've mentioned, you have to be quick, you have to have side branch access of both branches, so mini crush will be the best strategy. So you deploy a third stand, main branch crush, main branch stand, port, rewire, KPI, and can you play the video at the right lower corner? Okay, this is the final result. So mini crush, quickest way to secure both main branch and side branch. So in an unstable patient like this, probably if you want to be quick, DK crush may not be good. So mini crush will be your options to go. Okay, and the DK crush nowadays it is the more commonly accepted. However, it requires more steps and but it has a better metal distribution in the carina, so it has a higher chance of successful KPI. And of course, because there are various studies so that they have more evidence on this efficacy. So-called DK crush, again, there are different type tips and tricks for you to do the good DK crush. So first of all, okay, on the left side, so you have deployed the side branch stand first, right? But for DK crush, you have to have some protrusion of the side branch stand inside the main branch, right? If you do not have good enough protrusion, then it is very difficult for you to crush the side branch stand strut to the side branch ostium. So after you deploy the side branch stand, then you have to have a high pressure polarization at the side branch ostium. The reason is we want to make sure that the stand is well opposed to the side branch ostium. It is especially important if you have a long side branch stand because, for example, if you have a long side branch stand, the size at the mid circumflex, for example, and the ostial circumflex may be different. So sometimes you may need you have a bigger pulsation balloon to have a high pressure to make sure that the side branch ostium stand is really good position, good expansion before you do the main branch crush to the side branch stand ostium. So this is the first tips I want to tell you. Afterwards, okay, you do the main branch crush, and also you can see that even after the main branch crush, there's a lot of metal in the side branch ostium. This step is again very important. So before you do the rewiring, usually you need to have a bigger. This is what I call the pot balloon crush before you do the wiring. So you can see that comparing the left side and the right side, if you do not do the pot crush, then there's a higher chance for your wire to go to the wrong place when you do the first side branch rewiring. And after the pot crush, then you want to do the side branch rewiring. Again, this side branch rewiring there's also some tips and tricks, right? So first, you have to make sure that your wire do not catch, right, to the side branch ostium. So usually, I personally loop the wire through the main branch. Some people like to use a dual lumen catheter. And for the rewiring, I personally recommend you to do the mid cell, right? Because you can see on the diagram in the middle panel, if you go to the two distal cell, there will be a lot of stand distortion if you want to go to the most two distal cell and do the ballooning. So mid cell usually is the best place for you to do the first rewiring. And after to do the first rewiring, again we do the balloon, kissing balloon inflation, and then we deploy the main branch stand, doing the part, and of course you have to make sure that you do the part before you do your second rewiring. This is again very important tips and tricks. Okay. Afterwards, after the part, you do second rewiring. Usually, second rewiring is much easier than the first rewiring because we have created a hole in the side branch ostium. So the second rewiring usually is much easier. So afterwards, KBI and then pot balloon, right? So this is the sequence of a DK crush, and these are also the different tips and tricks for you to perform the DK crush smoothly. Of course, nowadays, we also have some other so-called DK crush modifications. For example, there's a so-called D crush, which means that for the main branch crush balloon, they intended to use a bigger balloon, right? So they use a bigger balloon that around the size of the proximal main branch. So first, a very low pressure at the carina, and then they move the balloon more proximal, just like the pot crush that I've mentioned, to make sure that we have a very good crush before we do the side branch rewiring. And also the SK crush or DR crush just mean that they just do the sequential balloon dilatation of the side branch ostium before they put the main branch stand. So these are the DK crush modifications. The last one will be the nano crush, right? So the nano crush nowadays, again, have some popularity. The good thing about the nano crush is that it is much easier, less step than the DK crush. the rationale of doing the nano crush is that it has a minimal protrusion to the main branch, and so it is actually similar to mini crush, but there's a less protrusion. But the drawback of performing a nano crush is that sometimes there may be difficulty in doing the rewiring, and sometimes you may miss the ostium, especially you do not have a very clear anatomy of the bifurcation, and sometimes the patient heart is beating, the stent is moving. Sometimes you may miss the ostium, and you ended up actually doing a reverse tap stenting. Right, so these are the diagram of illustrating the nano crush. So the side branch ostium, you have a very minimal protrusion, and afterwards you perform the main branch stent, and then you do the port, and then you do the port, and then you do the side branch rewiring. And actually you can see that even after the main branch stenting and port, you can see that there's a lot of space inside the side branch ostium for you to do the rewiring. And so if your wire go to the left side as in the left panel, so actually the wire go through the true side branch stent ostium. So when you do the KBI, actually you end up in a so-called reverse tap, but not a really a crush stenting. On the right side, if you go to the far distal cell, right, again, there will be a lot of difficulty when you deliver the different devices, and there will be a lot of distortion when you do the 1-1 balloon ratio KBI. So nano crush had its good, and it also had its drawback. Okay, so ladies and gentlemen, in conclusion, crush technique remains a very important skill set for upfront student two-stent bifurcation PCI. And evolution and modification of crush technique result in various types of crush. If you want to be fast and elegant, so you can do a mini crush or a nano crush. But if you do more steps, or if you want more evidence to support the two-stent strategy, then DK crush will be the technique for you to go. So that's the end of my presentation. Thank you very much.
Thank you, Frankie. Talk about all the crush. So before I'm asking the panelists, so my question is, which one is your favorite one?
So if the patient is stable, I opt for a DK crush. If the patient is not stable, I want to be quick, then I will go for mini crush.
All right. So I'm inviting all the panelists if there are any question or any comment regarding all the crush maybe in your daily basis in your lab. Maybe Glendon.
Yeah, very nice talk, Dr. Frankie. Regarding nano crush, because one of my colleagues actually went to Hong Kong and he came back to my center and started using a lot of nano crush. So, what are the evidence of nano as compared to DK? And will the angle actually play an important role for you to decide whether, because sometimes it's very angulated, how much do we need to judge in? So, will an angle play an important part for us to decide whether it's a DK or a nano?
Yeah. So for evidence, I would say there's no RCT, of course, to show that nano crush, DK crush, or mini crush, which is better. And for the angle, I think it's also important, right? So for nano crush, if you really want to do, right, then you need to have a very good angiographic view for you to really play out the main branch and side branch, so that you can try to have so-called the minimal protrusion. But I have to say that if you perform nano crush, it's actually a shorter mini crush, and you have to prepare that sometimes you may miss the ostium. If you miss the ostium, right, then for the main for the rewiring, you have to try to wire the most distal strut of the main branch stent, so that after you balloon, the main branch stent strut will try to cover up the proximal side of the side branch ostium. But again, even if you miss the ostium, it's not the end of the day, right? You can still have flow, maybe higher chance of ISL, but you can also bail off using a DCB, it's still okay. But you have to prepare that you may miss the ostium if you want to do the nano crush.
Your tips here is, how much do you think we should want, just barely a strut or?
Yeah, for nano crush, theoretically it's just one layer of sand strut after you crush. It's theoretical, but true in real life it's very difficult. Even I do the branch test, it's not that easy.
All right. Thank you. Since we really behind the schedule, thank you, Frankie, for your presentation.